We hope that you are safe and healthy. It's definitely challenging times with the COVID-19. First of all, thank you so much for all you do in the OR, especially now more than ever. We appreciate your work and we appreciate your taking the time to join us tonight. My name is Meltem Çetin. I am the Asia Regional Marketing Manager and I'm based at Intuitive Headquarters in California. We welcome you tonight to Intuitive webinar on para-aortic lymphadenectomy tips and techniques for accelerating the progress curve. Please note that we have live translation to Chinese and Japanese languages in this webinar. To access the translation, please click Interpretation button at the bottom of your screen and select your language. There may be a 5 to 10 second delay as the audio adjusts between channels. I am honored to introduce you to Dr. Peter Lim, who is the host of this webinar. He will share his expertise and experience. Dr. Lim is a very experienced Da Vinci surgeon. He performed over 3,500 cases since his training in 2008. He completed his fellowship in gynecology oncology at Mayo Clinic, Rochester, Minnesota. He is currently the medical director of gynecologic oncology and robotic surgery at Center of Hope in Reno, Nevada. He is also clinical associate professor of obstetrics and gynecology at the University of Nevada School of Medicine. He performs surgeries in 3 hospitals: Renown Medical Center, St. Mary's Hospital, and Northern Nevada Hospital. Dr. Lim has published many peer-reviewed clinical articles. He leads key training and teaching events about Da Vinci for Intuitive as a US case observation site and lead for TR500 GYN Oncology Master Course, which takes place quarterly in Sunnyvale, California. He's also an invited guest lecturer on Da Vinci around the globe. Please note that this webinar is being recorded. At the end of this presentation, we will open the floor for questions and answers for about 15 to 20 minutes. Please feel free to submit your questions via the Q&A box that will show on your screen at that time. And now I will turn it over to Dr. Peter Lim. Dr. Lim?
Thank you, Melton. To my colleagues, my Asia colleagues, thank you again. Again, as Melton said, I hope you're all staying safe in these challenging times and everyone is well, to your family and all. Again, it is an honor to be invited to speak to my colleagues. I wish I was there. I miss you all out there. I wish I was there physically. Again, thank you for giving me an opportunity to present to you all. So we'll talk about this morning the challenge of aortic lymph node dissection robotically. As we all know, periaortic lymph node dissection is one of the integral part of surgical staging for gynecological cancer. Where the challenge is as demonstrated in this, we may have grossly positive lymph nodes along here as this demonstrated left periaortic in this left picture. And to remove all these grossly positive lymph nodes to perform a lymphadenectomy, resulting in this. The lymph nodes along here, here's the left IMA. But the challenge of the periaortic lymph node dissection for many of us is this region, the left infra-IMA region, what I call as box number 4, or left supra-IMA. What we want to do is we want to recreate the same type of surgical procedure as the gold standard of open surgery. Whenever we perform this form of a lymph node dissection, this is basically what you want to do is have this same type of recreation of this lymphadenectomy as is demonstrated on this. So the objective for this this evening discussion is the rationale for robotic peri-aortic lymph node dissection. As we move towards open to minimally invasive, many of us were performing laparoscopic peri-aortic lymph node dissection, which is the first minimal invasive. But there are challenges to doing that, particularly the upper peri-aortic lymph node dissection in the setting of a high BMI patient. So we're going to basically see, I'm going to hopefully demonstrate to you what the rationale for, where the rationale for robotic peri-aortic lymph node dissection and what the clinical value in incorporating the Da Vinci or the robotic surgery. And hopefully I'll demonstrate the clinical outcomes on some of the key publication data and what my learning curve has been, and demonstrate to you what the literature supports of learning curve and how many cases that is required, if you will, to be able to adopt this specific procedure, incorporating into your robotic surgical procedure. And I'm going to move along in what this technique of a peri-aortic lymph node dissection robotically in this form of a simple procedure where sentinel lymph node sampling, either of the pelvic lymph nodes or the peri-aortic, and then early surgical staging, and where the complex peri-aortic lymph node dissection robotically in the setting of where it's high BMI body habitus. This is the difficult part. When you have a high BMI, getting up to the left peri-aortic lymph node dissection, more commonly known as box number 4, how to get there to remove these lymph nodes, the left infra-IMA lymph nodes, or the grossly positive pelvic or peri-aortics. And finally, I will talk about what the value, the economic value with increased OR efficiency, and about what I call the quantifying the impact factor, basically meaning that what the impact factor in incorporating the robot, how it translates to performing a successful peri-aortic lymph node dissection, resulting in better outcome, less complications, and which translates to decreased hospitalization and ultimately leading to economic financial outcome for patient and the hospital. So when you look at the robotic surgery compared to laparoscopic and open surgery, when I first started back in 2008, there were very, very minimal literatures. Now, this is interestingly enough, this is a meta-analysis a publication of comparing robotic surgery compared to laparoscopic and open surgery. This was 2008 to 2012. Now, remember, this was the very early adoption of all the surgeons that were performing robot, because GYN robotic surgery really was adopted in 2005. And in the GYN oncology arena, we really didn't start taking off until about 2008. So this really demonstrates the earlier experience of all the robotic surgeons. This meta-analysis revealed 1,200 citations. So within 4 years after the first GYN procedure was approved by the FDA, approximately 1,200 publications came out. 97 full-text articles were reviewed. 44 studies, and 30 were comparative and 14 non-comparative. And what they basically, to summarize in the literature, what it supports is robotic surgery consistently confers shorter hospital stay compared to open surgery. The proficiency plateau seems to be lower for robotic surgery than for conventional laparoscopy, meaning that the ability to adopt robotic surgery was much quicker when compared to laparoscopy, and I'll show you some of the data for that. And robotic surgery is superior over open surgery for management of endometrial cancer. And this is really key to this, because as you all know, at least in the US, endometrial cancer is the most common procedure. And what population is most affected by endometrial cancer? Majority, at least in the US, are patients with high BMI. And to perform open procedure for endometrial cancer, these patients oftentimes will have prolonged hospitalization, big incision, increased morbidity intraoperatively, secondary to their body habitus, okay, which then subject them to down the postoperative period where they are subjected to wound infection complication rate, potential hernia from the big midline scars that we perform, prolonged hospitalization resulting in immobilization, increasing the risk of DVT. So robotic surgery has, in this meta-analysis, has shown to be superior to open surgery. So the robotic surgery shows an advantage over laparoscopic surgery in cohort patients with high BMI in management of endometrial cancer. And part of the reason why is because in a high BMI setting, at least in the LAP2 trial, where they compare laparoscopic to open, the laparoscopy, when you perform in a high BMI setting, there was at least a 25% chance that if you start off with laparoscopy in a high BMI patient, they were unsuccessful in completing the procedure, particularly along the peri-aortic lymph node dissection. So hopefully I will demonstrate to you and make a case for why robotic surgery, peri-aortic lymph node dissection, is better than laparoscopic or open. This is another meta-analysis by Dr. Lim, comparing operative outcomes between laparoscopic and robotic surgery, specifically for endometrial cancer. Again, 36 retrospective study, 2 matched case control, and 1 randomized control. And basically, in this meta-analysis, when they compared robotic surgery to laparoscopic in treatment of endometrial cancer, what they saw was shorter hospitalization, less blood loss, less conversion, and less overall complications in favor of robotic surgery compared to laparoscopic. What about robotic peri-aortic lymph node dissection? This was the earlier studies performed by Herdy, and this was published back in 2015, as you can see, in International Journal of GYN Cancer. And this was a retrospective multi-center study consisting of 11 European centers and 1 US center in collaboration with SERGs. The study analyzed the outcome of robotic peri-aortic lymph node dissection of nearly 500 patients between November of 2004 and March of 2012. So this is very, very, very early on in maturation. So it's an 8-year. Peri-aortic lymph node dissection was performed either as an isolated procedure or at the time of the hysterectomy, pelvic lymphadenectomy, or omentectomy in staging. They basically look at two different approaches: extraperitoneal approach, which made up about 12%, while majority, nearly 90%, was made up of a transperitoneal approach, which is the approach that I use. The primary aim of this study was to evaluate the safety and feasibility of robotic-assisted periaortic lymph node dissection. And secondary aim was to compare extraperitoneal versus transperitoneal approach. And these are the results. You can see operative time, blood loss, and length of stay. The transperitoneal approach, okay, with combined or isolated procedure, the extraperitoneal approach. And what they have demonstrated in this, they concluded that the robotic-assisted periaortic lymphadenectomy is feasible. The mean and median number of lymph nodes retrieved are comparable to published results for conventional laparoscopy. Okay, so this was basically showing the number of lymph nodes retrieved were 12. This is just periaortic lymph nodes, not including pelvic. And it shows the combined procedure versus an isolated procedure. And if you look at the transperitoneal versus extraperitoneal, the number of lymph nodes retrieved were the same. Okay, and what they saw was the hospital length of stay was longer in the isolated periaortic lymph node cases, and transperitoneal isolated periaortic had a longer hospital length of stay than the extraperitoneal, regardless of the patient's age and or BMI. So they reported the conversion or complication rate. Again, conversion was very low, about 0.8, less than 1%. 4 of them got converted to open, and 2 patients went from robot to laparoscopy. I'm not sure why, probably because of the surgeon comfortability of when they're starting off, reverting back to their comfort zone, if you will. That's what I think would probably happen here. And the intraoperative complication was about 4%. Postoperative complication was 22%, they reported, and they graded it. But the highest rate of complication was formation of lymphocysts, is what they reported. Lymphatic complications were the most frequent, and 32 patients, or roughly about 6.6%, had lymphocysts. Probably as a result of maybe the absence of use of hemoclip, vessel sealers, etc. And I'll allude to that a little more, because remember, these patients underwent robotic periaortic lymph node dissection in very, very early part of the robot adoption procedure. This was a study that was just recently published by Loverix, Vergatis, the Belgium's group, looking at periaortic lymph node dissection surgical staging for locally advanced and cervical cancer, comparing robot versus conventional laparoscopy. Nearly 200 patients were enrolled. 2/3 were laparoscopic and 1/3, or 3/4, was laparoscopic and 1/4 was robot, if you look at it. And if you look at basically the postoperative complication, the rate of postoperative complication for robot was 7% as opposed to 15% for laparoscopic, okay? The operative time were very similar. Blood loss was less, but that's not clinically significant, if you can see. And postoperative hospitalization was comparable. And what they concluded was robotic periaortic resulted in similar progression-free survival and overall survival in a 2-year follow-up. The higher periaortic lymph node count was achieved after robotic surgery they were comparable to laparoscopic, and robotic periaortic staging was associated with lower EB blood loss and shorter hospital stay. This is our own data that we just recently submitted for publication, and we'll hope that this gets accepted, but I will share this with you. We looked at the laparoscopic versus robot-assisted pelvic and periaortic lymph node dissection and reporting on surgical outcomes and the review of the literature, okay? This is majority of the patients were endometrial staging and ovarian cancer staging, and small group constituted cervical cancer. This is the largest series that I'm aware of in the literature. Nearly, as you can see, 300 patients. The equal 175 were laparoscopic and 135 were robot. The age and body index were very similar. The operative outcome was shorter for the robot group. Again, blood loss was less. We found that to be statistically significant. Not sure that it's clinically significant because really 200 cc versus 77 cc's. The retrieval of the lymph nodes, they were higher for both pelvic and periaortic, but if you look at the node counts, they're very comparable to the literature. Now, why did this group, the laparoscopic group, had higher lymph nodes? And the reason why that the laparoscopic group had higher lymph nodes were that when I was removing the laparoscopic lymph nodes, we tend to piecemeal the lymph nodes in multiple pieces. And I think that attributed to the higher lymph